So, give me an idea. I mean, no harm chatting. Give me an idea, Daniel, of what is the percentage of vertigo cases who come into your practice?
Percentage of vertigo patients would be
Yeah,
about
as against
50%.
audiology, the plain
Yeah, general
hearing test patient,
audiology would be
right?
50%.
Oh, you have 50-50 breakup. Huh?
Yeah, yeah.
Okay. And how much of it is investigative, or do you get into rehabilitation, or you stay with
I stay
investigative?
with investigation only because we have a very good physio team in our hospital.
Okay.
So they take care of that. And then medical rehabilitation and all of that treatment, the ENTs, neurologist are
So
very
this is the
helpful.
Bethany Hospital.
Yes, yes,
Yeah.
absolutely.
And this is also in the Hiranandani buildings.
Not in my clinic. In my clinic, which is in Hiranandani, I
Okay, your
do,
clinic is in Hiranandani.
yeah. So there, my wife is a physiotherapist, so
Oh,
she takes care of rehab there.
oh, so
So in that way, we have that advantage.
that turf is defined here. Right, I
Yeah.
get it. That's then you have no choice. Let me put it like that.
Yeah.
Rashik, what about you? How many of the patients who come to a neurology OPD actually have vertigo?
So I would say, so many patients do present with vertigo,
Okay,
and so yes, so we have a separate headache clinic, and as we
separate
know that
headache clinic.
headache,
Okay,
headache clinic, and predominantly patients they have migraine, and out of migraine we have observed that most of the patients are having vestibular migraine
okay.
component. So that way in our headache clinic also we see many uh, patients with vertigo.
Vertigo. I
And
mean,
there are
these are histories which you have to
vertigo.
elicit, or they come up complaining about that per primum.
They mainly complain with present with headaches, sir. And when we check for the when we assess for the vertigo thing, uh,
That's when you find them.
it's when we find them that
Mm.
they have vertigo. So also there are many patients who overlap, sir. We have noticed that patient with headache, they come, and when we assess, we then realize that the patient end up having benign paroxysmal position of vertigo. Because the thing is, it also the PPPV component also gives some headache, some heaviness in the head. So that is more bothering sometimes. Sometimes that is more bothering, and they present with that.
Okay, fair enough. Good. So, how many people are online? Have we reached the magic figure? Not yet. Okay, so we'll just do two or three more questions and then let's start because we don't want to lose time in that sense. We have a limited time of what's our time now? Yeah. Okay, so we can wait 5 minutes. And what is the focus on vertigo among the neurologists? Because it's been my experience, at least initially during my training period, the neurologists would treat vertigo if they wanted to, otherwise they'd say it's autological in origin. So without much focus, partly because they were so busy dealing with cases. I don't know how much
Right.
of they are dealing with cases because they have a little more time at their disposal, or how much of it is because you all start subspecializing.
So, thing is that there are many patients who come with vertigo, and we deal with the patients with vertigo. Like, for example, so now as the respiratory infections are so commonly seen in this current issue, there where the respiratory infection is so common, there are many patients who present with vertigo second because of vestibular neuritis post URTI. So there are
Okay.
many patients which we have noticed that even I think a couple of days back, sir, there was one patient who presented with dizziness which is persistently there, new onset dizziness, sir. This was an acute onset, and the patient had an history of preceding URTI around a week back. So this dizziness, which was persistent, it was not increasing or improving with head position, and there was some hearing oral fullness also. So I have noticed that This is very commonly seen now, labyrinthitis component, vestibular neuritis component. And again, sir, vestibular migraine, we have seen many patients with incidence, increased incidence of vestibular migraine. And also, when we treat these patients, we have noticed that the headache component of these patients, the headache, and they improve a lot. The frequency and the severity of headache decreases, but the vestibular component still persists. There is not a significant improvement in that.
Okay.
Yes, sir.
Good. So I think now I'll have to wait as we have very gradual accrual of people. It's reached 12. So I think we will wait another 2-3 minutes, and then Daniel, we should read it. So let me do one thing. Let me at least introduce the speaker of the day. The speaker of the day is Daniel Jonas. Daniel Jonas is an audiologist who has an American certification, who was trained in the Nawab Ali Awar Jung Institute, which is very famous in Bombay, who currently works in his private clinic, which is Health Cura at Hirandani Estates, and with Bethany Hospital, which is a multi specialty hospital. He has over 15 to 25 years of experience, possibly more, and is focused on research in auditory processing disorders and in vertigo ailments along with general audiology. So he's a well-rounded scientist, and therefore we look forward to hearing from him. To comment on his experience of this particular kind of problems, we have Dr. Reshik. Dr. Reshik is a young standard bearer of neurology, one of the new breed of neurologists, I would say, who's adopting a core specialization of vertigo. We need many more like him because it is often an orphan child in the neurological specialization. Dr. Ashik is a Mumbaiker in the sense he is from B.Y. Patil, his graduation and undergraduation, and he has done his neurology in the Jaslok Hospital, which is, of course, if I may say, world famous, and therefore has a vast clinical experience. He's currently practicing as a neurologist in Navi Mumbai, and I think he would add the right touch of expertise in an area where usually otolaryngologists find it difficult to manage or difficult to assess because of our slightly less than perfect knowledge of the entire central nervous system. So I think with these few words, we would start the presentation. I don't know whether we have a quorum as such, but we assume it will add up. I don't know how many people are on board. We have 11. So, Daniel, I think we could you could start slowly and hope that people will come as it goes, because let's have a good discussion. Let it be a group of people who are interested rather than just numbers. Go ahead,
Yes, sir.
Daniel.
So thank you
Awesome.
for introducing me.
Sorry.
Thank you, sir. Thank you for introducing me,
Oh,
sir.
not at all. No, it's a pleasure. I wish I could spend time and be more fulsome, but I thought let's keep it academic. The basics we will talk about. So, Daniel, I think if it's okay, you want to wait a little more, we can wait
No,
also.
I'm good. I'm good.
You're
I'm good.
good to go? Fine.
Yeah.
Yes.
Thank you,
Mm,
sir, for that
not all.
lovely words of introduction. And I'll just take over the screen.
Sure.
Okay, here we go. So, good evening, everybody. And just I'd like to share a patient with you all, which was reported sent to me as a referral for patient post-stroke with complaint of imbalance. And so because as this patient came into me, so these are the findings that I'd like to share with you all. And just a little bit of information about the patient. Patient name, Mr. A.N. Age, sex, 65 years, male. Complains difficulty in walking and constant dizziness. Needed somebody to always accompany him while walking into the clinic and anywhere he goes. Is a very established businessman, but post-stroke, the dependency on people has made him quite disabled. Even though he's able to walk around, but constant help has affected his morale. And that is something where we come into play, and uh, it has been a pleasure that we've been able to help him out in this matter. And I'd like to share his findings when we first met him. So these are his second time the MRI brain angiography findings, which was on the 19th of April. Acute infarct in the right frontal region along the anterior part of the cingulate gyrus. Small punctuate infarct in the right temporal subcortical and cortical region, and chronic lacunar infarcts in the right external capsule and the left thalamus. Mild periventricular white matter flare hyperintensities, possibly representing chronic microvascular ischemia. Mild cerebral atrophy and chronic ischemic changes, no significant flow limiting vascular stenosis or vascular lesions in cerebral and neck vessels.
How old was the patient?
65 years.
65.
Yes. Chronic lacunar infarcts in the right corona radiata, external capsule, and bilateral thalami. Focal area of gliosis in the left frontal periventricular white matter and adjacent cingulate gyrus.
So,
So,
Daniel, if you don't mind,
yeah.
just go back one slide.
Yeah.
So, let me just start asking Dr. Reshik to tell us something. For an age of 65,
Right.
do you think this is abnormal or normal? This atrophy, ischemic changes. I
Right.
agree, infarcts may be abnormal, but what would you think for an age of 65? Is this something as a
So,
baseline which is abnormal?
right, sir. For an age of 65, clearly we can see that this is an abnormal finding. There are multiple punctate infarct which has been mentioned in the right temporal lobe, small punctate infarct. That could be a possibility of lacunar chronic infarct. As we can see in the MRI, the only infarct which is an acute one is the right frontal region. The other findings, all those findings which we are able to see here in the slide is the small punctate infarct in the right temporal cortex, flare hyperintensities, multiple flare hyperintensities, and so
Dr.
all
Reshik, you
these things
would like to
are linked
speak up
to
a
small
little?
vessel disease.
Dr. Reshik, could you
Hello,
speak
sir.
up
Can
or
you hear me?
increase your mic a little?
Yes, sir. Can you hear me now?
Yeah, now it's better. Go ahead.
Yeah. So, sir, it is clearly seen that we are dealing with something known as small vessel disease.
Okay.
Because there is multiple flare hyperintensities. There are right temporal, cortical, subcortical region infarct, and an acute infarct is seen in the right frontal region.
Okay.
That too, it is in the anterior part of the cingulate gyrus. So again, it is a subcortical region. So whenever we see flare hyperintensities or acute infarct in the subcortical region, we should always think of a small vessel disease infarct.
Like you would get in diabetes and such like.
Exactly, exactly. So that is what the next point comes. As we went through the history, comorbidities is an important part which we need to know in here.
Yeah, no, so
65-year-old male.
we'll come to that. So let's take each issue one by one and then take it further. So I think the message is very clear that if you find this picture, you should think of small vessel disease, and
Exactly.
superimposed on that, you had an infarct. So that's
Right.
a good take home message for all of us, because we tend to read the end result of the MRI. We don't read the fine print.
Yes, sir.
So this is a good point. Go ahead, Daniel.
Yeah. Yeah.
So I hope you don't mind my interrupting you like
No,
this,
no,
because
absolutely. This
at
is
the end we may
creating.
not remember the questions
Yeah,
which
yeah.
come
No,
up.
no, you've piqued my interest in small vessel disease, so wanting to read more and learn more.
Good.
Yes. So coming back to the VNG findings. So just going through a few findings, the subject had no spontaneous nystagmus in light, but in dark, left and upbeating nystagmus was observed. So you can just have a look at the video, just share with you right now.
Yeah.
So this is what was observed. Then post high frequency head shake, left and upbeating nystagmus, post hyperventilation, left beating nystagmus was observed. So this is the post high frequency head shake, which is it's a during head shake, and then we go to
So the direction of the segments is predominantly to the left.
yes, yes, yes.
Predom-
That was something always seen. Okay, there was no gaze evoked nystagmus with fixation, but without fixation, then left and upbeating nystagmus. Again, the same thing seen. Pursuit tracking was mildly saccadic in both horizontal and vertical planes. Saccades was affected in horizontal and vertical planes with a step up and step down pattern. Now, to avoid any kind of artifacts so that we just simply don't get it, I put off the lights while we did it. So, like with the lights on, we tried to see it, and then with the lights off, and saw that we got consistency in the findings that were there. Optokinetic responses were not preserved in all directions, and as you can see in the video, what you can see in both the graphs and in the previous graphs, you can see that when there is left to right pattern, you will also see uh, a upbeating nystagmus, and in every finding there is, if it is horizontal expected, vertical also is there. Vertical is expected, there's horizontal also. So these were the findings that we found. So indicators of central lesions in VNG: direction changing nystagmus, gaze evoked nystagmus, vertical nystagmus, Q deviation, dysymmetric saccades, oculomotor abnormalities, non-fatiguing nystagmus, not associated with vertigo at times. And that is the case presentation. Thank you.
Okay. So let's now start, because I noticed that in your title you mentioned intranuclear ophthalmoplegia. My understanding was intranuclear. Rashik, you could comment on this. Intranuclear ophthalmoplegia classically has features of disconjugate movements in the eye, which
Yes.
was not really seen in the gaze nystagmus, was it? In the gaze testing.
So, usually, sir, when we are dealing with an INO case, the gaze test, clearly in the horizontal gaze test, we should find a ocular misalignment.
Mhm.
The reason is, sir, when we are dealing with INO, internuclear ophthalmoplegia, the the lesion is in the medial longitudinal space. So clinical presentation or the clinical sign, what we find is ipsilateral loss of adduction of the eye because of the medial rectus involvement of the third limb, and when the contralateral eye on abduction will have an nystagmus only while doing a contralateral movement, sir. Apart from that, on fixation, or if the eye is moving towards the other direction, there shouldn't be any nystagmus. Only when there is a contralateral movement of the eye to, that is the abduction, on abduction, there should be a nystagmus. And there should be a loss of adduction of the ipsilateral eye. Here in this case, sir, I think the gaze movement, horizontal gaze movement was normal. Of course, there is upbeat and left beating nystagmus, as Mr. Daniel mentioned. But the misalignment was, I couldn't appreciate that much here in the horizontal gaze test. So, and also, sir, INO, internuclear ophthalmoplegia, when we are talking about clinical history, they are usually sudden onset where patient will complain of diplopia. There should be some diplopia, double vision, when the patient presents presenting complaints. And because the causes of INO, when we know that we are dealing with INO, we need to evaluate and find out the etiological cause of that. The most common cause is lacunar infarct in the midbrain area, which is midbrain to pons area, which is sometimes we don't even pick up it in the MRI also. The
So
MRI finding comes
in this case, did we have that finding in the? I don't recall
Yes, there was
specific. There was.
diplopia in this case.
No. Did
There
you
were.
have an infarct in that pontine area?
I'll just.
Could you just show us again? Or could you check and let us know if it is?
or we can just go through the horizontal gaze also, sir, once.
The thalamus, it is there.
Problem is there, sir.
Below, it's not seen. Okay.
Yes, sir.
You want to see the gaze video again?
Yes, sir. Would be better if we go through it
Okay,
again
just
once.
give us the gaze video again, Daniel. Just go back to screen sharing and see. Are you having a problem? Yeah, okay, fine. It appears to be a bit conjugate, right? I mean, there's not too much of dissociation. Or am I, Rasik, did you spot any dissociation?
I couldn't appreciate much, sir.
Okay, fair enough. Go on. So, as you said, basically, you're looking for dissociation in gaze nystagmus,
Yes, sir.
right?
Dissociation and gaze nystagmus. So, dissociation as in the adduction of the ipsilateral eye should be complete loss. There should be a complete loss of adduction of the ipsilateral eye.
Okay.
Yes, sir.
And I recall reading there would be preservation of convergence at
There should be
times
preservation of conversion.
and convergence. So,
There
so
should
I
be
think when you're looking, but then we didn't see an infarct in that area as such,
we didn't see any impact,
or
sir.
they
We
didn't
didn't see any
report it.
impact.
Maybe
So,
they
sir,
stopped at the thalamus. They didn't go any deeper. I don't know, or lower. Is that
maybe so, or there could be a possibility that there is an entity, complete entity known as MR negative stroke, sir. So usually
right?
when we when we deal with a patient with isolated INO, we we know that the infarct size would be a tiny infarct, which sometimes a 1.5 Tesla MRI or 3 Tesla MRI can't pick up. Yes, sir.
So what
Sometimes
would
the
be the strength of an MRI which you would be happy with?
so 7 Tesla, sometimes 7 Tesla can pick up
And is it
such.
commonly available in Bombay?
It is not much available in
Could you
not
name a
commonly.
center which has it?
7 Tesla, sir, it is available in, I think, corporate hospitals like HN Reliance Hospital and Kokila Bain in Andheri. They have 7
Okay.
Tesla. The area where I worked, just local, they had 3 Tesla MRI, sir, which is also good enough. Sometimes uh, I'll just share my experience, sir, uh, if,
Go ahead.
if
Go ahead,
I'm,
no problem.
yes. So we had a patient who was young, maybe in late 20s, who presented with a diplopia, acute onset diplopia. And on neurological examination, sir, we found out that patient was having disconjugate movement, mainly on horizontal eye movement, and patient was having a left abducting nystagmus. There was a loss of right eye adduction. So clearly, we were suspecting INO in this case. So we decided to do an MR imaging of that patient. So the MR imaging showed absolutely normal. There was no in fact there was no finding suggestive of small vessel disease as well, because the patient was a young female. There was no risk factors, and so we started evaluating. We started finding out the cause of this, whether we are dealing with a vascular phenomena, whether we are dealing with an infective or an inflammatory phenomena here. So as we realized that this patient is a young patient, possibility of a inflammatory phenomena can be possible. So we started trying to find out etiological causes. As we know that pathologically inflammatory can be a possibility here. Then we realized that demyelinating disease is an other cause for INO. Usually, very uh, classical presentation is bilateral INO. When we sometimes see bilateral INO in a patient with demyelinating disease, very commonly seen in MS. And if you see bilateral INO in a patient, we confirm that we are
So
dealing with an
when
MS.
you say INO, you mean intranuclear
Yes, sir.
ophthalmoplegia. And when you
Yes, sir.
say MS, you're talking multiple sclerosis.
Multiple sclerosis. Sorry,
Right.
sorry, sir. Multiple sclerosis.
So
So,
here's a question.
we,
When you have INO, how often do you get only INO, or how often do you get INO as part of a CNS injury?
yes, sir. So, isolated ano is a very rare presentation, sir.
Okay.
So, the reason why I remember this case is because this case was an atypical presentation. So, here also, sir, we
You could pep up your voice again. I think you'll have to hold it here.
yes, I need to hold it
Yeah.
then. Yeah. Can you hear me, sir, now?
Yeah, now I can.
So, here what we decided that MRI brain contrast, as we know, when we are dealing with inflammatory, the inflammatory area will pick up the contrast. We did an MRI brain contrast, and we found that there was a lesion in the midbrain, which is probably giving this finding of INO. So usually a multiple sclerosis patient doesn't present with INO, so they have typical presentation of unilateral pain in the eye. So they have many other presentations. INO is a rare presentation. Sometimes there was one more case which we had discussed, that patient presenting with 1.5 syndrome, which is again INO plus presentation, an isolated INO, and there is something known as INO plus, that is 1.5 syndrome. So the concept behind 1.5 syndrome is as as we discussed that in INO there is ipsilateral loss of adduction of eye, and there is contralateral abducting nystagmus. In 1.5 syndrome, what happens is the ipsilateral eye will have complete loss of movement. Not only the adduction, the abduction of the eye will also be affected. This we are talking about the horizontal gaze movement, sir. And on the opposite side, sir, in the opposite eye, the adduction will be lost and contralateral abducting nystagmus will be seen. So one, the whole horizontal eye movement is gone. That's why one, and half of the contralateral eye movement is affected. So that's a 1.5 syndrome. So
Good. So I think what we can do now is, Daniel, could you share with us your readings on, the findings in a cortical lesion, especially as it applies to nystagmus, and then we'd come back and get Dr. Reshik, maybe get Dr. Kripa also in. Uh, let
Hi, sir.
maybe
Good evening, sir.
Hi Kripa. So I'm going to call you in now, but
Sure.
let Daniel first present his findings, and then we can chat. Come, Daniel.
Certainly, sir. Certainly.
Go ahead, Daniel. You want to present your readings on the findings? Yeah. So I believe you're presenting the VNG findings if the lesion is intracranial, correct? Yeah, I can't hear you. Maybe you're on mute.
Mm.
You're on mute, Daniel. Yeah,
Yeah,
go
yeah,
ahead.
I
Yeah,
just put
go
this
ahead.
out. Okay, so these are in cerebellar findings.
Yeah.
So gaze evoked nystagmus, dysymmetric saccades, abnormal pursuit movements, ocular dysmetria, multidirectional nystagmus, saccadic pursuit, ocular flutter, and ataxia.
You could spend some time explaining these concepts. That'd be interesting.
Yeah. So the main thing in cerebellar regions, and this is something that in the hospital since the time we've been starting to do VNGs, is most cases when they come presenting, okay, this may be BPPV, but then when we show them in the positional movements, when the head position isn't changing, there isn't much nystagmus. But as soon as the gaze is taken away, means actually the visual input is taken away and in darkness, and then the nystagmus starts. And this is a very clear cut sign. And that is when the discussion goes, okay, now we need to start considering central causes. So these are in gaze evoked nystagmus. Then dysymmetric saccades, many a times we would not get that square pattern which we see generally on the graphs. You will see a step up, step down pattern which was shown earlier. And and in abnormal pursuit movements, generally our main focus is in the horizontal than vertical. Vertical I have seen is many a times affected in patients past 35-40. We would see it slightly saccadic. And I think so that is why batsmen retire after 35, because I think the vertical pursuit movement gets affected, and because of the slight delay, I think so they're getting bold. That is my current understanding, I think so. And then we have multidirectional nystagmus, ocular dysmetria. The eyes don't move. Then sometimes we've seen in some cases is one eye, the pupil expanding much more as soon as we cover the eyes. So these kind of responses we have seen. And ocular flutter, and we would see kind of a very rhythmic pattern of nystagmus, not a standard slow phase, fast phase. Uh, Ataxia, we would see again that we would catch it in saccades. Uh, and again, now we coming to VNG findings with patient with brain stroke, gaze evoked nystagmus, impaired saccadic eye movements. Again, as I said, you would not see the square tooth pattern, skew deviation, uh, ocular motor abnormalities while we were discussing what we
Interleukin
call as
ophthalmoplegia.
ocular ophthalmoplegia. And what we have seen is like while in wards, when we go in to see the patients, especially with stroke, when you take the eye, we move it, ask the patient to follow your finger, and that is when we see one eye moving and the other eye not moving, and very clearly, and when during intense like in the ICU and all. So these kind of findings, that time we would not do a VNG currently, but when you just do it in bedside evaluation, very much seen. Impaired balance in cortical stroke, visual field deficits, the virgins affected in such patients, cognitive and perceptual deficits, abnormal ocular movements that, as was explained earlier, altered visual attention. Like patient would say, looking at one thing would get me affected or would get a headache, or also sometimes they would look through you like you are glass. So these kind of things are seen in patients with stroke. So these are findings we've been seeing.
Okay, so I just want to introduce Dr. Kripa. Dr. Kripa is a person who's focused, who's an otolaryngologist who's focused on vestibular diseases and works in Bangalore currently. Uh, Kripa, in your experience, if you have intracranial problems, how
Yes,
often
sir.
do you pick them up clinically versus do you pick them up on VNG?
Sure, sir. So first of all, Dr. Mr. Daniel, I mean, I would like to say a very good evening to both the expert panelists today. Hello, Mr. Daniel, Dr. Rashik, sir. Yeah. Having said
Good
that,
evening, Dr. Kripa.
hi. So Daniel sir has very well capsulated the findings. One thing I would like to add to what he has already told, of course, apart from a saccadic pursuit in horizontal and vertical, would be what I routinely do is a chair rotation test. Yeah.
Is
Why
a,
chair rotation?
could you just repeat?
Yes, sir. Sir, a 180-degree chair rotation test.
Chair
Yeah.
rotation. Yeah.
Yes. So what happens in that is definitely we do it with vision allowed, followed by vision denied, and then there's a protocol of VOR suppression. So many a times, if there's a midline cerebellar lesion like flocculus, paraflocculus involvement is there, so the VOR suppression, which is a function of these two areas of the cerebellum, will be poor or will be altered in these patients. Yeah. So that is one in whenever you are talking of cerebellar in terms of cerebellar lesions. Sir, and could you just repeat the next question? I mean, what was the other thing you asked,
No, no.
Avinash
So
sir?
what
Huh.
I'm saying is, how often do you um, pick these up on
Right.
VNG versus a clinical examination? And that
Ah,
same
ah.
question I would pass on to Resik after you answer.
Absolutely. So one more thing. For example, if we are dealing, this is one just a case with the help of a case, I'll try to explain. There was a lady who had 30 falls, 30, when she was referred to us. Of course, she had been to all possible doctors in Bangalore. And then, so when she came to us, that was around 6 months back. So 30 falls in 1 year. Yeah. So when we saw her clinically only, so what basically it was a case of progressive supranuclear palsy. Now, in this patient, there was clinically also, we could see the vertical saccades were clearly affected because she presented at a very late stage, I would say. But earlier, I mean, Dr. Rashid can, of course, add to this. But what I feel is, if if you do a VNG, I mean, and if we have missed doing it clinically or it's very subtle, the vertical saccades being affected can be easily picked up in a VNG because it's reproducible and even the subtle changes the earlier cases can be identified and yes, since it's a progressive disorder, progressive supranuclear palsy, I mean as the way I look at it, it's early, the earlier it is caught, the better. Of course, I would like Dr. Rashik's input on
Yeah.
it.
So here's another question: does the hyperventilation affect central nystagmus?
So to me,
Yep. To
yes,
you.
yes. So many times in loop, I would say only in cases where there is a loop. Yeah, a loop compressing the an ICA loop compressing the fascioacoustico bundle or the seventh eighth nerve complex, or say, it is definitely the higher Chowda's classification type 3 or type 2. In these cases, many a times hyperventilation tests comes positive in VNG.
Okay.
Yes. And I would
Broadly,
yes,
go on.
I always advise a CIS 3D MRI in these cases just to not miss out on
Yeah.
this.
So
So
no, so we'll come back to you. So I think the pattern is emerging that if in your VNG you find vertical nystagmus, if in your VNG you find disconjugate movements, if in your VNG you get dysmetric saccades, you
yeah.
tend to think about a central pathology. Am I
Yes,
right? Yeah. So
absolutely, sir,
could
absolutely.
you could Dr. Esik, could you come in now and maybe address the same thing from your perspective? How often would you? Sorry.
Sir, we are getting some disturbance. I mean, some host will have to mute Mrs. Sana.
Mrs. Sana, yeah, okay, go ahead. Rasik, could you enlighten us on this? How often do you rely on a VNG or pick up intracranial pathology on a VNG versus a clinical examination?
Uh, yes, sir. So many patients, as also Dr. Krupa gave a wonderful example of progressive supranuclear palsy. So there are many patients in when we are dealing with Parkinsonism. These patients they have less systemic findings of Parkinsonism. They mostly have ocular findings. So
Your
in
mic, your mic.
Hello? Yes, sir. Yes, sir. Yeah. So when we talk about ocular
Yeah,
findings,
okay,
sir,
yeah, yeah.
now there were many patients in our ward where we tried to find out the imbalance in patient. These patients present with imbalance. So we do the clinical assessment. The Parkinsonism features are very mild, not significant enough to label as a clinical Parkinsonism entity. When we do VNG, there are certain points and certain findings which helped us to point towards Parkinsonism. Is firstly square wave jerks. So on spontaneous fixation, sir, we in dark as well as in light, uh, we notice that plenty of patients are having square wave jerks which are significantly high. I would also try. I would also like to give an example of a 55-year-old male, sir. He came with the chief complaints of uh, dysarthria, low volume speech. The speech has gone down. Apart from that, on clinical assessment, there was no evidence of Parkinsonism, and we did VNG. And in the VNG examination, we saw that the patient was having significant square wave jerks. Almost, I think, in a minute there were around 40, 44. So, which was significant, sir. Ultimately, on follow-up, we after 3 to 4 months, then the Parkinsonism features came up. On clinical examination, patient became slow. Patient was having difficulty getting up. There was some stooping of posture. There was some tremors, ipsilateral. It's not ipsilateral, sorry, asymmetrical tremors. So here VNG played a major role here to help us find out that one small findings which is suggestive of Parkinsonism. And again, uh, there was a patient of progressive supranuclear palsy. So in VNG, we saw that the vertical gaze is restricted. So there are many patients where we see that the vertical gaze is significantly restricted. The horizontal movements are still intact. And
So yes.
in early PSP, as Dr. Krupa mentioned, that there is something known as round the house sign, sir, which is a clinical sign. But again, in VNG also, we could appreciate that, sir, that the eye on vertical examination, vertical movement, the eye makes a round and go up. It makes a circular round and it goes up. Unfortunately, I don't have a video, sir. Otherwise, I could have shared it. So both the eyes they make a circular movement and they go up, which is a classical early sign of vertical gaze restriction, which we see in progressive supranuclear palsy.
Yes, which was the case
Uh,
in this patient also, sir. Horizontal saccades were unaffected. Only the
Yes,
vertical range was affected. Yeah.
yes, sir.
Yes.
so
And
go on. Go on,
one more case, sir. Sorry,
please.
we had a patient who uh, presented with the history, very uh, odd history that the patient while walking was bumping to a side, was hitting objects on the side. So he came with the chief complaint that he is not able to walk. His vision is little unaffected. He is not able to properly focus on one thing. And second thing, on the wife gave a beautiful history that while having food, he completely left the half part of the food on the plate unaffected. He didn't have the half uh, plate of the food, and the rest half of the plate he had completely. So we clearly understood there is some visual field defect. The thing is, this patient only had visual field defect. On clinical assessment, also clinical examination, also we found that there is some visual field defect. But on gaze examination, sir, when we had a gaze examination on fixation, we could clearly see that the movement on the right side was affected significantly. We did an MRI and we
Hmm.
found out there was a left intracranial lesion. So these patients, that patient only had visual field defect. There was no apraxia. Usually in cortical lesions, what we see is apraxia, we see agnosia, we see language dysfunction. And in parietal lobe lesions, there is no significant motor findings. But this was one thing which we noticed. Additionally, that in VNG, that the movement of the eye was affected.
So I think what you're talking about is homonymous hemianopia and quadrantic also. That's
Yes,
why
sir.
it was a parietal lesion.
Exactly.
So that's very interesting. In fact, Daniel had pointed
Hmm.
out that he noted pupillary abnormalities in intracranial. So I think one should look at the eye slightly differently beyond the spectrum of only nystagmus. One should
Hmm.
Correct.
also look at pupils, and one should also look at visual fields,
Hmm.
right?
Yes.
So that's
Yes.
another take home, which so we are in general, when you as a neurologist, Dr. Esik, assess VNG, do you have a pattern of assessing VNG to rule out various lobes, or do you just look for abnormalities in general and then infer?
So,
Say, for instance,
pattern,
let me make it more specific. In a lesion in the cortex, say frontal region,
yes, sir.
what abnormalities would you look for in the VNG?
Yes, sir. So in frontal lobe,
Your
sir,
mic again. Your mic again. Yeah.
frontal region, sir, frontal
Yeah.
lobe, we have our frontal gaze center. So
Yes.
the frontal gaze center plays a major role in contralateral horizontal movement of the eyes.
Hmm. Hmm.
The contralateral horizontal movement of the eyes, frontal gaze is the primary center
Okay.
in the brain. And from the frontal gaze center, the pathways goes to the pontine paramedian reticular formation contralaterally,
Yeah.
and then our extraocular cranial nerve nuclei plays a role.
Correct.
So we have noticed that some patients, for example, this case with acute right frontal infarct, or sometimes a patient with space occupying lesion in the frontal lobe, they has they have some disconjugate movements, sir. They have some disconjugate movement on the contralateral horizontal movement. So they tend to have an gaze preference towards the ipsilateral side of the lesion, towards the side of the lesion, because the contralateral horizontal eye movement is affected.
And then parietal, you said that you're more likely to get hemianopia, if at
Yes,
all.
sir, if at
But
all.
otherwise, it is relatively silent, though it may be more manifest in the motor regions. Am I right?
Yes, a motor region, and as well as there will be multiple symptoms where patient will have confusion,
Your
and
mic, sir. Your mic, Rashik. I think,
where
sorry, you're taking it
patient
from me.
will have no problem, sir, no problem.
Yeah.
Where patient will have confusion, and usually as parietal lobe has a direct connection with the dorsolateral prefrontal lobe, prefrontal cortex. These patients are not that attentive. So unfortunately, many patients, as we know, during the VNG, cooperation is quite uh, needed from the patient side as well. So that
Absolutely.
many times we can't get that cooperation usually in these parietal lobe lesion, because they're very quite inattentive. The working memory is fully down, so they don't focus.
And
And
the temporal lobe, what would you find it? Would you find any VNG abnormalities in temporal lobe?
the temporal lobe VNG examination, so no, sir. VNG examination in temporal lobe, hardly, sir. But occipital lobe, we can, sir.
Occipital lobe?
Occipital lobe, yes, we can, sir.
Specifically,
Occipital
if
lobe,
you may.
again, homonymous hemianopia is a finding which we see when there is a patient has when the patient has occipital lobe lesion,
Right.
where we can see. And second thing, sir, sometimes in as the optic tract is affected, it goes through the lateral geniculate body and to the lobe, occipital lobe. Pupillary asymmetrical can be seen when there is a lesion in
Correct.
the optic pathway when it reaches before prior reaching to occipital lobe. So connections of the occipital lobe can have some pupillary asymmetry, usually when there is a lesion in lateral geniculate ganglion, which
So,
is just
so
prior to the occipital
yeah.
lobe.
So to summarize, when you think of the frontal, you're looking for gaze specific
Yes, sir,
nystagmus.
mainly frontal. When
When you're
we
thinking for parietal, you have to look at visual fields.
right, sir,
When you're thinking of occipital, also you're looking at visual fields.
we look at
Uh,
the visual field.
Temporal is something which is relatively more silent vis-a-vis this. So one
Right, sir.
small, and of course cerebellar has been beautifully explained by Daniel. So
Yes, sir.
where
Yes,
and Kripa also regarding the tendency for dysmetria, the tendency for
So,
inability to suppress
vestibular ocular
things on the
reflex.
rotation chest. That's
Yes.
so. I think a pattern is emerging of what you can look for. So, and one additional question which I would like to know is, what would be the Bera and cortical evoked response audiometry addition to this? Like in these various lobe involvements, would cortical evoked response audiometry help? Anybody could take it.
We can do the P300 and check. I have never done it, but it would be affected, I think so, in temporal lobe issues. So P300 may come negative. So these are one possibility, but I have not done it.
Uh, do
so
you have
then
any input, Dr. Asik?
yes, sir. So usually when we do somatosensory cortical evoked responses, this somatosensory area, that is, as Dr. Daniel sir mentioned, that temporal lobe, uh, yes, temporal lobe sometimes we do get. There is some delay in the evoked potential in the temporal lobe lesion, and we can also see if there is any lesion in the sensory motor cortex of the parietal lobe. So the evoked potential are little delayed, and the amplitude of the potentials are also little low when we see a lesion in the somatosensory cortex of the parietal lobe.
So that could be an added test which one could do. I think I'm thinking in, if you have an MRI negative,
Yes, sir.
apart from a VNG, you could add a evoked response audiometry also. How about the Bera abnormalities in, say, like if you have things like brainstem involvement, would expect a Bera abnormality also?
Yes, sir. If the Bera,
Your mic,
we,
your mic.
if
Asik, yeah.
we are suspecting a lesion in the vestibulocochlear nerve, vestibular nucleus, yes, sir, Bera can be abnormal. We do pick up. In fact, there are many referrals which we get from the neurosurgery team where the patient has acoustic neuroma and they would like to do Bera test. So many of these patients, their Bera is delayed. The Bera is abnormal, especially when we are dealing with vestibulo-ocular nerve and vestibular nerve nuclei involvements.
No,
Yes,
so
we
I
can
was
do
actually sorry. Go on.
multiple rate Bera and then look for delay. And that we have seen in brainstem and uh, auditory vestibular nerve, any kind of, even some kind of schwannomas and all, we've seen a delay
No,
happening
so
in.
the reason why I asked this question is, when we do VNGs and I mean, the knee jerk is to look at the MRI. But let's assume you're talking about an MRI negative lesion. I don't think people have adequately studied the cortical evoked and brainstem along with VNG. Maybe that's a fertile area for study, because things like acoustics and all that are fairly straightforward. You would expect it because it's the
Yes,
auditory pathway. But classically, Bera being brainstem issue, I think that is an area which I would urge you all, when you get cases, if it's possible to do both those testing, especially
Hmm.
Yes,
Bera
sir.
doesn't require even any, patient cooperation in that sense of the word. It might be
Right, sir.
interesting to
Right, sir.
do that as a study. Do you agree, Krupa?
So absolutely, it's a wonderful idea.
Right. Uh, Rasik, you want to share some more cases, some more of your of your experience, in the sense, how would you clinically manage these cases after? So let's assume the patient has come to you, you've done these investigations, you suspect a stroke, MRI positive or negative. What actually do you do thereafter?
So, when we deal with such patients, or when we are dealing with an acute stroke, now as we are discussing about the brainstem involvement, where the patient has predominantly the posterior circulation is affected. So we need to find out first thing when we are dealing with stroke is whether the stroke is a small vessel stroke, or it's a large vessel stroke, or it's a cardioembolic stroke, sir. Now, small vessel stroke are usually lacunar infarct strokes, where the predominant areas, the predominantly majority of the strokes, small vessel strokes, are involved in the subcortical area, as we discussed that the subcortical white matter, basal ganglia, thalamus, also pons, pontine area are very predilected to small vessel strokes. So these are areas which are predominantly affected when a small vessel stroke is seen. Second thing, sir, when now as we know that we are dealing with a clinical history and clinical findings of stroke, we go ahead with MR imaging. So MR imaging, we can find out whether it's a small vessel stroke. And when we do an angio in these patients, which is very important, the angio will tell us whether there is a atherosclerotic stenosis or an acute clot, acute thrombosis in the vessel,
By
in the
by angio, you
intracranial
mean
vessel.
MR angio,
MR angio, sir.
right?
Yes, sir. MR angio. So, uh,
Which you still
if
use
there is an
gadolinium, or you
atherosclerosis,
use any new drugs?
we don't use, we use gadolinium, sir, no new drugs.
Gadolinium.
Sometimes we do contrast angio, sir, contrast angio, where iodine is used, sir. Gadolinium, less likely. We use gadolinium for normal MR angio now. Yes, sir. So, in the angio, we see the large vessels, whether the large vessel has an atherosclerotic stenotic disease or an acute thrombus. So, once we know it's an atherosclerotic stenosis in the intracranial vessels. So, and the area of impact is also very important. The area of impact and the vessel which is atherosclerotic, with where there is an atherosclerotic stenosis, should be the circulating vessel. For example, if a patient presents with the right-sided weakness with a left internal capsule infarct, and the left internal carotid artery has a stenosis, that is an indicator of an artery to artery embolic stroke, where the cholesterol or the stenotic cholesterol plaque must have been ruptured from the ICS stenosis and caused an infarct, which is an artery to artery embolic stroke. Now, this could easily happen when we are dealing with a posterior circulation stroke, where patient present with pica infarct, patient presenting with ICA infarct or superior cerebellar artery infarct, having a vertebral artery stenosis. So when we know that there is an artery to artery embolic, so we know that the culprit behind is that the large vessel stenosis. So here the antiplatelet therapy and statin may not be sufficient. Sometimes we might have to do an intervention to tackle that stenotic vessel, so that there shouldn't be a recurrent stroke, sir. So there are criteria to find out whether these stenotic vessels are the culprit or whether intervention is needed. We do
Hmm.
multiple tests like carotid Doppler. vertebral artery Doppler. We also do CT contrast angiography. We also do digital subtraction angiography just to study the stenotic vessels. Once we find out that the stenotic vessel, the criteria is basically, sir, if there is an infarct and if the stenosis is more than 50% of that corresponding vessel, we have to intervene. And if there is no infarct, if some, for example, if the patient presented with TI, there is no actual infarct but transient ischemic attack, and we found out there is a stenosis, so not necessarily we need to intervene it, even if the stenosis is more than 50. And sometimes there are many patients with asymptomatic stenosis of the vessel. In asymptomatic stenosis of the vessel, the stenosis should be more than 70%. That is a time when we intervene. The intervene, as in we are talking about a mechanical intervention. So when we are dealing with an artery to artery embolic phenomena, here dual antiplatelet
Your
and
mic again.
statin
Your
is the
mic.
first.
Your mic, sir.
Dual
Yeah.
antiplatelet and statin, yes sir, yes sir. Dual antiplatelet and statin plays a major role, but at the same time we need to find out whether that stenotic vessel need to be intervened or not. So small vessel infarcts, then artery to artery embolic. As I mentioned, stenotic vessel is one of them. The second is acute thrombus. So when we know that there is an acute thrombus and the corresponding region of the brain has an infarct, we know that this is an acute clot. And if the patient presented within 24 hours of onset of symptom, then there is something known as mechanical thrombectomy. Mechanical thrombectomy is an urgent mechanical intervention, sir, where we do a DSA, digital subtraction angiography, and with the catheter, the approach is usually femoral artery, sir. And with the catheter, we remove the clot. So here, the mechanical thrombectomy is very commonly done for anterior circulation when we're dealing with internal carotid artery, sir, middle cerebral artery. But in posterior circulation stroke, sir, we restrict ourselves till the basilar artery. Posterior cerebral artery, which is an end branch of basilar artery, usually there are many patients with PCA clots, sir. Going till that and doing mechanical thrombectomy is a little complicated procedure because the vessels are more tortuous and the vasculature of the posterior circulations are little fragile, more fragile than the anterior circulation. So intervening that is little difficult, sir. So these are the two ways where large vessel disease can occur. One is artery to artery embolic disease. One is acute thrombotic occlusion of the vessel. Then the third thing is cardioembolic stroke. Now, when we are dealing with cardioembolic stroke, there are certain features which are telling us that we are not dealing with a small vessel infarct or a large vessel stroke. We are dealing with cardioembolic. Usually, such infarcts are bilateral hemispheric. There are bilateral hemispheric infarcts. For example, there are, and as we mentioned, the small vessel infarct are more subcortical. Here, the cardioembolic strokes are more cortical infarcts. There are more cortical infarcts, bilateral, and sometimes predominantly affecting the posterior circulation. When the patient presents, they must be having some arrhythmia. There must be having some tachyarrhythmias or bradyarrhythmias, and past history of ischemic heart disease. Some history of cardiac diseases should be there in these patients. Now, treating this patient and finding out cardioembolic, trying to separate them from other type of stroke is an essential part because the treatment, the management differs. As we mentioned, sir, that dual antiplatelet and single antiplatelet with statin is a main role in the other type of strokes. In cardioembolic strokes, we start oral anticoagulation. The antiplatelet therapy won't work. So that's why finding out cardioembolic stroke, pointing them out and separating them, finding out evidence of a cardiac diseases is an essential part because anticoagulation is totally different line of treatment. How do we find out cardioembolic events, sir? That is, first line of investigation is 2D echo. In 2D echo, we have to look for the left atrial
Cardiac
appendage,
pulsing.
stagnation of vessels,
Fair enough.
and
So tell
yes,
us
sir.
a few things about, I mean, we've almost crossed time. So just a few things about, so you admit the patient, depending on the type of stroke, you do the definitive thing. Thereafter, what is the usual
Right.
course in the hospital?
The usual course, sir. Now, the thing is, when we start the treatment of the patient, we know the size of the infarct and whether it's a small vessel infarct or a large artery infarct. There are some patients who may need an intensive care treatment, sir, because large vessel infarct, these infarcts are quite unstable, sir, because the large vessel infarct will have cerebral edema along the infarct area. So here, at least for 48 to 72 hours, we admit the patient in ICU. We monitor the patient's vitals. We have to maintain a good mean arterial pressure of around 75 to 95 mmHg, so that already there is an infarct in the large vessel, and we don't want to push down the BP further low. That might increase the size of the infarct. So we need to push the BP little on the higher side. We it is a story of 72 hours. So once the 72 hours to 3-4 days, the stroke resolves, the brain becomes little stable.
And
The
then I
next thing
suppose
what
you
we
go
have to
into
do
the
is
rehabilitation zone, I
rehabilitation part.
assume so. So I think we are
Yes,
running
sir.
out of time. So
Rehabilitation part.
yeah, go on.
Yes, sir. Rehabilitation part. Finding out the risk factors and tackling them is an essential part, so that we don't have a recurrent stroke, and an adequate secondary prevention line of treatment, that is medication, which includes antiplatelet or anticoagulation statin.
So I think now we've reached about the end of this period. So I think I definitely appreciated the entire. I think we have covered a large gamut of this area of intracranial, especially stroke related illnesses, starting with Daniel's excellent presentation of uh, VNG findings added by both Kripa and Rashik's inputs regarding specific areas of the brain, how we can try to look for findings in the VNG. Of course, added with clinical examination, high index of suspicion. And Dr. Rashik was very kind to tell us what happens later. So we all know now that if you get a case like this, you need to refer him for active treatment within a window period of 24 hours and warn the patient that he would need hospitalization for 3 to 4 days and step in again for rehabilitation at the end of the story. So I think we have a broad picture of intracranial lesions causing vertigo. And I think I must thank the panelists for having elucidated all that. I think I really enjoyed this discussion and I learned a lot from it.
Yes, sir, same,
If
sir.
there is anything which
Me too, sir.
feel free to add. Otherwise, I think we
Yeah.
can. Do any of the participants or the speakers like to add something? We are open to it.
Nothing.
So,
Thank you, sir.
Thank you
Thank you,
very
Dr.
much. So
Rasik.
then I
Thank you.
Thank
think
you, Dr.
we
Krupa.
Yeah.
we
wonderful
really
presentation
I
from
really
Yes,
Daniel.
yes.
enjoyed the
Thank you, Dr.
presentation
Krishna.
and the
Thank
Yeah.
you,
discussion.
sir.
Thank you
So
very
I
much.
would just like to congratulate Mr. Daniel, sir, for the excellent presentation, and Dr. Rasik for his very kind and very useful, fruitful inputs.
Yeah.
Thank you, sir.
And we would try
Thank you,
to
ma'am.
summarize this in a newsletter to circulate because I
Absolutely.
think a lot of people who missed it due to various reasons. I think this is the puja period and people are
Yes.
still recovering. So that might explain the thing, but I think they missed something which is very interesting. Thank you very much.
Yes, sir.
Thank you.
Thank you. Good night, everyone.
Good
Thank you.
night.
Good.
Thank
Thank
you,
you.
Thank
sir.
Good
you.
Good night
night.
all.
Good night.